Very good afternoon to one and all. I'm sorry I couldn't make it in person. I'm giving a talk today on neuromuscular ultrasound. The introduction. So, the diagnosis of peripheral neuropathy is based on clinical and electrophysiological examination as a neurologist. And the clinical examination will include your evaluation of motor and sensory weakness. And electrophysiology, of course, is going to give you an idea on where exactly is the pathology. Like you have an involvement of motor, sensory nerves, or there any conduction blocks are there. So it helps you to localize where the pathology is. Now, what is the limitation? You're not going to really get an idea about the spatial information about the nerve anatomy or its surroundings. So this is what is this is where ultrasound really comes into play. A high resolution ultrasound is a non-invasive imaging technique which provides in real-time examination of soft tissues in static as well as in the dynamic states. Now, the improved spatial and contrast resolution of this technique has made it really possible to virtually depict almost all the nerves in the limbs and extremities with excellent details. So, as a neurologist, you're going to localize clinically where is the lesion, and you're going to have an added on benefit of what sort of pathology you're going across. Like you're having a demyelination or an axonopathy or some muscle disorder. And of course, your ultrasound is actually going to give you your real structural and anatomical problem that you're handling. So, in prospective studies based on 1 year systemic use of ultrasound, it has been proved that it helps the clinicians to help in actually solving the differential diagnosis and helps in patient management in a high number of atypical cases at clinical and neurophysiological examination. I will be also giving you some videos at the end of the talk of some of these atypical cases where ultrasound has really helped us to make a diagnosis. Sorry. Now, the technique that we are going to use is make the patient sit on the bedside, comfortable position, either sitting or lying down, based on what nerves you're going to actually examine. And the probe that we're going to use here, we've already had, I think since afternoon you must have listened to TCD and carotid Doppler talks. Now, the probe that we are going to use here is a high frequency probe, which is either a hockey stick probe, which you can see here, or it will be a linear probe with almost a higher frequency than what we use for the carotid duplex scan. Now, these probes, why do we use a higher frequency probe? Because they're going to give us a very good spatial orientation and very good resolution, and we don't need to go very deep for most of the nerves because they're very, very superficial. Now, the objectives is to identify the peripheral neurosonoanatomy, to identify the common peripheral nerve entrapment sites and how sonography helps to narrow down your differential diagnosis, understand the importance of scanning of non-neural structures as potential source of pathology. So that's the most important. Neural structures are one. The secondary pathologies or the non-neural structures like your muscle, your surrounding connective tissue, your joints, those are the ones which have to be studied along with because they may be the ones which is actually causing the nerve pathology. So know the role of ultrasound in differential diagnosis and assessment of severity of peripheral nerve pathology. So the role of ultrasound in the peripheral nerves has improved considerably with newer developments and with the availability of high frequency probe. As we have already seen, the superficial course of the nerves is the most important thing. So you're going to scan most of the nerves really well. Common sites of entrapment I think all of you will know your carpal tunnels, your cubital tunnel syndromes, peroneal nerves at the fibula head, tarsal tunnels. They're all very beautifully visualized by using an ultrasound. And what we're actually going to study is your fascicular pattern. Very, very important in this is the nerve course can be completely tracked, which cannot be done by the MRI. So use of the MSK ultrasound to identify the non-neural source of pathology. Now, the structures which can be studied are anterior horn cells, plexus, that's your brachial plexus, the peripheral nerves, and of course, you can also have a role of ultrasound in muscle disorders. Now, mononeuropathy is very important, traumatic nerve injuries to see if there's any neuroma, there's any transection of nerves, and also helps you to prognosticate what is and what intervention needs to be done for these patients. Neural tumors, very beautifully visualized. Entrapment neuropathies, of course, it has a very big role. Polyneuropathies, we have a role in CIDP, and ultrasound has some very characteristic features of Hansen's. Now, the classical peripheral nerve has a structure with this is a structure which is seen on your microscope, and the same thing that we're going to get on the ultrasound. So you have an epineurium which is surrounding the fascicles. The individual fascicle inside you have the perineurium and the endoneurium within the just surrounding the myelin or the axons. So it's the epineurium, the perineurium, and in between you have the fascicles, and then you have an endoneurium inside. Now, the median nerve is just a classical example how it looks on an ultrasound. You can see that it has a very honeycombing pattern or a starry sky appearance. That's what they call it. You have the epineurium, which is echogenic. Perineurium is also echogenic, and you have the nerve fascicles, you can see here, which are basically hypoechoic. So this is the classical structure, which is very similar to your microstructure and comparable to your ultrasound. So just a picture to show you the comparison between the two. The normal nerve, you always look at two sections, the transverse and the longitudinal sections. In the transverse sections, you have a honeycombing or fascicular pattern. And in the longitudinal sections, you have two parallel echogenic lines and with lot of echogenic lines in between. That's basically your perineurium. So this is how it looks on an ultrasound. Again, this is just a picture to show you how it looks on an ultrasound. You have the various fascicles, the epineurium and the perineurium. Now, you have, when you're keeping your probe down there, you're going to see a structure like this. So imagine almost your muscle fascicles, your nerve fascicles, your nerve, everything is going to may look almost alike. So one important feature that I think when during the demonstration session can be shown is nerves do not demonstrate anisotropy. That's the most important part. What is anisotropy? So whenever you're going to shift your probe up and down, to and fro, your echogenicity of the nerve does not change, unlike your muscles and the surrounding fat tissue. Now, the most important sign of a compressive neuropathy that you're going to pick up on an ultrasound. A compressed nerve exhibits a fusiform swelling which is hypoechogenic and appears maximal in proximity to the compression point where the nerve suddenly flattens. Now, the nerve compression has various stages. Now, once you have a compression, you will have an increased permeability of the endoneural vessels. You have an endoneural edema, increase in the endoneural fluid pressure, further obstruction of vasculature, and you're going to get some sort of an injury to the nerve fibers. So this endoneural edema is what you're going to actually present as a fusiform swelling. Now, just to look upon the common entrapment signs, which I've already mentioned to you about. Now, this is just a pictures showing the median nerve, ultrastructure anatomy at the level of the wrist entry point, the entry point of the carpal tunnel. So how do you recognize the median nerve? You can see there a hypoechogenic structure there. You have two bony landmarks. So remember, nerves can be studied very close to bony landmarks, like the peroneal around the fibular head, the median between the pisiform and the scaphoid, ulnar at the level of cubital tunnel. So these are all points where you can actually identify the nerves more easily and then track them up or down the lane. So the carpal tunnel anatomy, you have the flexor carpi radialis very close to that. And just to show you that in the transverse section, this is how the median nerve looks. And just over the median, you have median nerve, you have a flexor retinaculum. Why do we have to do an ultrasound? So we are doing an electrophysiology. We're going to localize that we have a carpal tunnel syndrome by your conduction blocks or your inching methodologies. Now, why do we have to do it? Very important is we have to identify whether it's an idiopathic or a secondary cause. Now, idiopathic, usually you may not have any secondary causes, just you will get a fusiform swelling and a flattening of the nerve at the level of the carpal tunnel. And in the secondary causes is the most important. You can pick up ganglion cysts. You can pick up tenosynovitis, very commonly associated at the level of the wrist joint, especially in thyroid people with hypothyroidism or women who are having a lot of traction and they use their wrist for all the activities. And underlying lipoma, or you can even have structural anatomical variations. So if you're going to operate these patients, you're actually going to tell the surgeon what he's going to find there when he's going to open up. So the nerve swelling or enlargement, can you see here, is what we're going to appreciate both in the transverse as well as in the longitudinal section. In the longitudinal section, you can see that what we call as a notching, where there's an entrapment or a thinning or narrowing of the median nerve and a proximal dilatation that you can see very clearly. Now, the direct ultrasound signs, hypoechogenicity increases, enlargement happens proximal to the obstruction. You can get the notch sign. You will have a lot of hyperemia or increased vascularity because of the venous edema around the median nerve. Now, another important thing is you have a hypoechoic enlargement just proximal to the level of obstruction that I have already mentioned to you. Now, the cutoff points that we have some criteria which we take as a normal is less than 9 mm square. Borderline cases are between 9 to 12, and abnormal is more than 12 millimeters square. So this picture is very beautifully showing you the secondary causes I was talking to you about. One is a ganglion cyst, which is very hypoechogenic and indirectly causing your median nerve, your carpal tunnel like syndrome signs. And you have another case here, tenosynovitis, lot of hypoechoic areas just around the muscle bundles that you can appreciate at the level of entry of the carpal tunnel. Now, this is again another case where very important is you're going to get a bifid median nerve in at least 10 to 20% of cases you're scanning for the carpal tunnels. And sometimes you will have a persistent median artery right in the center. You can see there a red dot there, which is present. So when the surgeons are operating, they have to be very careful about not injuring this. So the most important is the next thing, we go to the ulnar nerve. Just showing you just a gist of some of the important nerves and where we actually scan them and what findings we can get. And then we're going to finish off the talk with some interesting cases. The ulnar nerve is found at the level of the cubital tunnel, and it can be scanned all along. And you can see at three different points how the ulnar nerve wraps around, the bony prominences there. And a very important entrapment site here is between the two heads of the ulnar flexor carpi ulnaris, which we can see in many of the cases. Now, cubital tunnel syndrome, again, more than 9 mm square area, you're going to call it an enlargement, and hypoechoic and enlarged. Sometimes a mild hypoechogenicity can be seen in a normal ulnar nerve. So don't mistake it, because we have a repeated traction that is occurring there even in normal individuals. Okay, so just to show you. So this is another very important aspect of doing an ultrasound is all your dynamic studies, because you have a condition called the ulnar snipping or snapping, and it can be very easily treated by just doing a transposition surgery, and an MRI can never pick this up. So you're going to do a flexion extension, and you're going to look for snapping of the ulnar nerve, and that makes a diagnosis, and you're going to tell the surgeon to operate upon these cases. So just completing my talk with some very interesting cases. So we had one patient here with a scar. Can you see the scar on the wrist? So he had an injury with a glass, with a glass stick about 1 year ago, and he was asymptomatic after that, after the suturing was done. No median nerve distribution signs. So last 1 month, he came with paresthesias along the distribution of the median nerve. And what we found was there was a demyelination, but the conduction block was at the level of the wrist, not at the level of the scar. So this was the ultrasound I did for the patient. And you can see the median nerve is being tracked down, tracked all the way up from the level of the carpal tunnel. And we can see there that we're going up close to the scar, and then again I'll be tracking the median nerve down. See, now the structure is quite good, and now again I'm going to go down, and when I'm just going distally, you can see there's a place where there's a lot of hyperechogenicity around the median nerve, and then you can see the median nerve structure being preserved. Again, with some enlargement at the level of the carpal tunnel, at the level of the wrist entry. So this was probably a scar tissue engulfing the nerve. This is again the longitudinal section. You can see the median nerve being tracked, and very beautifully you can see there's some hyperechogenic structure which is surrounding the median nerve. Now, this patient we operated upon and had a lot of scar tissue. So much of scar tissue was removed, and patient was doing fine. These are just some pictures to show you. This is a case of neurofibroma. So these are all simple. These are cases which can be picked up very beautifully on an ultrasound. Yes, this is again another longitudinal section. Yes, you can see very beautifully a neurofibroma and of the ulna. So this is again a very interesting case. We had patient presented with the tarsal tunnel syndrome, and you can see. No, sorry, this is a case of tenosynovitis, and you can see a lot of hypoechogenicity around your muscle. Okay, and this is another interesting case of tarsal tunnel ganglion cyst. Yes, which is engulfing your tibial nerve. So this is how a cross-sectional, ultrasound of ulnar nerve look like in a case of Hansen's neuropathy. You can see the gross enlargement, hypoechogenicity, and there's an increased vascularity, destruction of architecture. Very classically, not at the joints, but above the joints. This is found about 2 to 3 centimeters above the elbow joint. So take home points. Ultrasound will help us to clinch sometimes the etiological diagnosis of the neuropathy. Surrounding tissues can be studied very beautifully. Should be done in case of mononeuropathies. You will end up with surprises. Easily repeatable and non-invasive. Excellent for procedures. Thank you.